Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell Eleanor Blum Patient Family Learning Center at Mass General. Today's program is part of our MGfC Family Centered Care Series, a special collaboration between the Blum Center and Mass General for Children. Before I get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted so you can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for it in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next, I would like to introduce you all to today's guest speaker. Joining us today, we have Dr. Ellen Braaten. Dr. Braaten is the Executive Director of the Learning and Emotional Assessment Program at Mass General, also known as LEAP. She is also an Associate Professor of Psychology at Harvard Medical School. She is widely recognized as an expert in assessing learning disabilities and attentional disorders. She is the co-author of many books and articles for parents and professionals, including the books Bright Kids Who Can't Keep Up, as well as Bright Kids Who Couldn't Care Less, How to Rekindle Your Child's Motivation. In recognition of National ADHD Awareness Month, she joins us today to give a talk on understanding and treating childhood ADHD. So please join me in welcoming Dr. Braaten.
Thank you so much for having me today. I will jump right in and share my screen. And give me 1 second to start the slideshow. Okay, so I'm very happy to be here to talk about one of my favorite topics, which is ADHD, something I have been researching for my entire career and also working with thousands of kids with ADHD over the last over 25 years of being a child psychologist. So ADHD is something that everybody already knows a lot about. In fact, I hear probably more than anything as a psychologist, just from people, just when they say, you know, when I introduce myself that I'm a psychologist, they'll either say, "Are you analyzing me?" or "Does everybody have ADHD?" So it's one of those things that we think we know a lot about. And ADHD can look sort of like this, especially in adults. It could, you know, look at all the half-finished projects lying around my house. For kids, it can mean look at all the half-finished homework assignments or all of the homework assignments that I did, but I didn't turn in. And it can also look like this. It can be sort of feel like anything unrelated to what I was supposed to be doing. Your brain is sort of drawn that way, and you're saying, what's happening here? But really, one of the things to think about when we think about ADHD is that it's a lot of different things, a lot of things that are ideas in one's head, lots of random interruptions that you can't control. ADHD is also pretty associated with anxiety for a few reasons. One is that we think that for some people, anxiety and ADHD are genetically transmitted together, but also when you have trouble paying attention, when you have a lot of interruptions that are internal, when you have a lot of ideas, when you're at this unbounded curiosity, a lot of things don't get done. So anxiety can come about because you haven't done the sorts of things that you need to get done. You're anxious about getting organized, attending to the things that you're supposed to be attending to, and even some insecurity about whether you can even do the job that someone asked you to do, because you don't know how to pay attention to what it is you're supposed to be paying attention to. So that's kind of why I've just given you the idea of what most people sort of think ADHD is, and none of those things are wrong, but it only really explains part of the picture. Let's really start with what is ADHD, defined by psychiatrists and psychologists based on thousands, tens of thousands really, of studies. And what ADHD consists of are three different core symptoms: inattention, impulsivity, and hyperactivity. Now, not everyone has all of those symptoms. Some people can have just the inattentive symptoms. Some people can just be more impulsive, hyperactive. And most people with ADHD have a combination of all of those. And let's talk about each one of these in separately. But one thing to think about is if you are a person with more inattentive kind of symptoms, you're going to look very different from the person who has more hyperactive and impulsive kinds of symptoms. So again, there are three different types of ADHD: predominantly inattentive presentation, predominantly hyperactive impulsive, and then a combination of the two. And like I said, the vast majority of people with ADHD have combined type, especially when we're talking about kids. Predominantly inattentive symptoms are more, that child who just can't pay attention to anything, who you ask them a question, they're like, what did you say? And you might even think that a child with inattentive presentation has a hearing problem or a memory problem, when really it's a problem with focused attention. Whereas a child who's mostly hyperactive, impulsive, are going to be moving around quite a lot and doing a lot of things, getting into trouble in some ways, doing things that are going to be inappropriate for the situation. And those two kinds of kids can look very different. In fact, some researchers, myself among them, think that maybe the predominantly inattentive type of hyperactive ADHD child is probably a different thing altogether. And I should bring up too that we use the term ADHD to describe both. In our diagnosis of ADHD, that term is used overall, even though a lot of parents will come to me and say, he's not impulsive or hyperactive at all. Why are you using that term? And it's because we use ADHD predominantly inattentive type. In the rest of the world, we might refer to that as ADD, attention deficit disorder, and leave off the hyperactivity, but that's not our correct way of using it. And by correct way, I mean our criteria. You can see the letters DSM-5. That's our Bible in the world of psychology and psychiatry. It's called the Diagnostic and Statistical Manual. It's the 5th edition, and it lays out all the criteria for different kinds of psychological, psychiatric, and learning issues. And so our criteria within DSM for inattention are these sorts of things. And a child who has or meets criteria for inattentive subtype ADHD has to have 6 or more of the following, and they have to have them a lot. So things like making careless mistakes, inattention to details, problem sustaining attention. Yeah, they can pay attention, but they can't keep their attention. They seem not to listen, like I mentioned before. That might even look like a child who has a memory issue or a hearing issue. They start stuff and they don't finish it. They have trouble getting organized. Sometimes kids with inattentive symptoms just don't even start the task at all, because they can look at it and say, I'm not going to be able to pay attention to this. I'm not going to be able to finish it, so I might as well not even start it. They lose things because they are inattentive to what it is they need in the first place, easily distracted, and forgetful. So those are the sorts of things somebody has to have 6 or more of those manifested very often. The criteria for hyperactive impulsive kinds of behaviors are things like this. They're exactly the sorts of things you would think about. A child who blurts out the answer before the question's even done, interrupts a lot, intrudes on others, has difficulty waiting their turn. So that impulsive, I've got to act right now. Or hyperactive. meaning they're fidgety, they have trouble staying seated, kids who have trouble staying seated in the school setting, they might have trouble even just staying seated while they're eating. Inappropriate kinds of running around, feeling restlessness, difficulty engaging in leisure activities quietly, or always needing a parent around to, oh, mom, please take a look at this, look at this, look at that. On the go kinds of kids, and kids who oftentimes talk excessively. Sometimes they're super engaging to be around, but it might be too much of a good thing. Again, you have to have 6 or more of these in order to get the diagnosis of impulsive hyperactive subtype. And a lot of times people will describe themselves as being driven by a motor. They just can't, it's like the motor is on and they can't turn it off. Now, I mentioned before too that the majority of kids with ADHD will have some of each of these. And in that case, for the combined category, a child has to have 6 or more symptoms of either inattention, hyperactivity, and impulsivity for greater than 6 months. So it's not the sort of thing that when a child has a stressor in their lives and they're just really inattentive or really kind of driven by a motor because they've had a change in school placement, trauma that's happened to them. That's not the same thing. What we're really looking for when we're diagnosing somebody with any disorder, but particularly ADHD, is we want to see, is this happening in a child's life for longer than 6 months? And the other really important piece of this, and this sort of gets to the answer of the question, is ADHD something that we all have? This helps to answer that question with the answer no, because the symptoms have to be pervasive, meaning that it has to occur in more than just one place. So for kids, they need to, in order to get the diagnosis, they need to demonstrate symptoms at home and at school, not just one or the other. So a child who might be impulsive or inattentive at school, but are great at home, well, we might be thinking there might be something going on at school that's giving them that difficulty, or vice versa. If a child's really impulsive at home, trouble keeping themselves pulled together, but are great at school, we might be saying to ourselves, well, maybe there's something going on at home that's causing those behaviors. So it's got to be pervasive. It can't just be in one place. It also has to be impairing, meaning that it can't just be like, oh, a bubbly, enthusiastic kind of child who does talk a lot, but doesn't get in trouble for that. So the impairment has to cause someone distress. And very much like we all can get anxious, all of us can feel depressed at different times in our life. We don't have an anxiety disorder or depression unless those symptoms impair us in our daily lives. The same goes for ADHD. It's not just that, I'm feeling disorganized, or it's hard for me to pay attention, but that those problems cause us to lose relationships, to not get work done, to impair our grades in school if we're a child. And it also has to happen a lot. It has to be something that frequently occurs. Again, not just something that happens on the weekends or something that happens in school when there are tests involved and the child's having trouble getting organized, writing a paper. That's a problem with a skill. When we're talking about ADHD, we're talking about pervasive symptoms causing lots of problems in daily life and happening a lot. So there have been a few changes along the way when we've looked at ADHD. Now, I should say that the first time that ADHD was the term was coined or something similar to it was in the early 1900s. It's thought by a lot of people who study human behavior, sociologists and evolutionary psychologists, that it is very likely that these behaviors that get us in trouble now were quite adaptive years and years, centuries ago. It might have been a very good thing to be somewhat impulsive at different times, or to be hyperactive, or even to not be so overly attentive to what was going on in the environment. Now, in our society, these skills have become more important. So there have been a few changes recently in our definition of what ADHD is. It used to be considered a disruptive behavior disorder. So it was under that umbrella that it was a behavior disorder. Now we consider it a neurodevelopmental disorder, meaning that there is a brain and developmental trajectory or connection with these behaviors. It's not something that a child's being disruptive, but that they have an issue with the way their brain processes information and is able to respond to information in the environment that causes those symptoms. We also have learned that ADHD can occur in adults, and it used to be thought of a decade or two ago that most people just grew out of these symptoms. Now we know that's not the case. We also know that you can be diagnosed with ADHD as an adult, even if you hadn't been diagnosed as a child. And for adults, when I mentioned before, 6 or more of those symptoms are required to get a diagnosis when you're a child, but when you're an adult, you only need 5. But we've got to have some symptoms before age 12. That used to be even younger, that you had to have symptoms before age 7. So the key here is that as an adult, it's not something that just came out of the blue, that inattention isn't something that just happened to you at age 40 or 50, but that when you look back at your history, you see that, yeah, I had trouble paying attention in school, or I never performed at a level that people thought I could be performing. And the other issues too that I just want to make a point of is that ASD, which stands for Autism Spectrum Disorder, used to be considered an exclusionary criteria. So if you were on the autism spectrum, you couldn't have ADHD and vice versa. Now that is not the case. And we are also calling these kinds of subtypes, hyperactive, impulsive, combined, inattentive, as presentations and not subtypes. That this is the way these symptoms present in the world, which seems a little bit less stigmatizing. So how do we make a diagnosis of ADHD? I've had lots of parents who have come into my office saying they met with a pediatrician for 5 minutes, they filled out a quick questionnaire, and their child was diagnosed with ADHD. As a parent and also as a professional, I can totally understand why lots of parents would think that is not good enough for me. I need more information. And the issue about getting a more complicated or a more complex evaluation is a good one for us to consider. And so I'll go over some of this in a moment. But 3 things to keep in mind. The diagnosis is still based on a clinical assessment of symptoms, looking at the associated impairment, which what I was saying, like, is there an impairment? Is the child struggling because of this? Are they not being able to make appropriate friendships? Are they not doing well in school? And then also the age of onset. So for example, if someone comes to me and they're 55 years old and they're saying to me, I'm having trouble paying attention, but I never had trouble before, it's probably not ADHD, and they need to seek a different sort of evaluation for that. There isn't any one single test that is available to diagnose ADHD. So it's something to think about. And I wish there was. There isn't a brain scan. There isn't any sort of EEG or anything like that. It's really a diagnosis made on the child's behavior. And there's some subjectivity to this too. We've got to look at the child's development, and it's context sensitive too, meaning if a child's in an inappropriate environment and having trouble paying attention, or if a child has a learning disability that's not being treated, they might have trouble with attention because of that and not because of a primary issue with attention. So I want to just review this because I get a lot of questions about how do I get an appropriate evaluation, and do I go through the schools or go through a private evaluator? At Mass General, and the executive director, as I was introduced, of the Learning and Emotional Assessment Program, we do a lot of evaluations of ADHD, but there are lots of ways to get evaluated. One is to go to someone like me or clinic at Mass General or person in private practice to get a neuropsychological evaluation. And that kind of evaluation is very broad. It's usually very long. You're going to get a lot of information about how your child processes information, their attention, their cognitive skills, their memory, emotional functioning. That's a great evaluation to get when you need more information about a child. But sometimes it's better to start, you can see my list here, with the pediatrician. And if you're really just wondering, my child's having trouble paying attention, things are pretty good, but not great. I'm not so worried about academic performance. I'm just worried about their behavior. Their teacher is worried about behavior, but nothing else. That can be a good place to start. A psychiatric evaluation is something that will happen by a child psychiatrist. And oftentimes you'll go to a child psychiatrist thinking that you might be considering medication for your child. And then kids can also get evaluated in school. So let me just go over this very briefly, again, only because I get a lot of questions about this. So school versus private evaluation. One thing to think about is when you get your child tested through the school, it's not necessary for you to get tested through the school if you think your child has ADHD. But a lot of times what happens is the teacher is the first person to notice this. The teacher will say, Jimmy's having trouble paying attention in school. I think they should be evaluated. And so what sometimes is done is evaluation through the school. School systems are great evaluators if you're looking for patterns of strengths and weaknesses, you want more information about how they're doing academically, and you want to know what services they need. School systems don't, though, perform those big neuropsychological test batteries. They don't diagnose specific syndromes, so they're not going to give you a diagnosis of ADHD. They don't tend to think like a psychologist about terms about brain processes, like what's memory like and how is that connected to a child's attention. And they definitely don't think diagnostically. So if you're really worried about your child having ADHD and you're like, I want to know, getting an evaluation through the school system is not going to give you that diagnosis. For that, you've got to get a private evaluation, either from a pediatrician, and that evaluation is going to be relatively brief, and that's how they're trained. There's nothing wrong with that. Or a psychiatrist, or a pediatric neuropsychologist, or a clinical child psychologist. And that kind of evaluation, like I said, much more comprehensive. When I do an evaluation like that, I'm going to get a lot of information. I'm going to start to think like, I wonder what the problem is here. I want to gain some insights about the child. I want to come to a formal diagnosis, which sometimes is ADHD when the parents are coming to me wondering about ADHD, but sometimes it's a learning disability. Sometimes it's a child who's very bright and in the wrong academic environment. So there are lots of other reasons it can be. So again, public school evaluations are good for figuring out if a child's eligible for services and not for making a diagnosis. So the whole point is, does the child have a disability? What kind of disability? And they'll figure out where that fits under the IDEA, the Individuals with Disabilities Education Act. They'll also answer the question, okay, so the child has a disability, but does that mean that child needs special services? And to be eligible for special education services, both of those things must be true. So if you get a private evaluation for ADHD, you might know if the child has a disability. You might bring that report to your school, and the school might say, well, that's all well and good, but we don't see that this child needs support in the school. So that's a different question, and I'll leave that for now, but if you're curious about that, please ask about that in the chat. So when is getting a firm diagnosis important? Well, when you want to make sure your child is getting the best treatment, when you don't want to waste any time getting help for your child, when you want to be an active, informed participant. Sometimes it's that your child's teacher is like, I don't know how best to teach this child. Can you get an evaluation outside of the school so we get an idea about that? And also having a firm diagnosis helps you get insurance reimbursement to pay for the treatment itself, especially those outside of school. The private evaluations for ADHD, so I have some of these. The pros are that you get to pick the evaluator, you control who sees the report. It may or may not be covered by insurance, but the negatives are what I just said. You might get this evaluation, child might be diagnosed with ADHD, and the school says, well, we don't see the problem here at school. And the other cons about getting a private evaluation is that there's usually a pretty long wait for an appointment, and it's not always covered by insurance, and it can be pretty expensive. So on the other hand, here are some of the pros and cons for getting a public evaluation. Again, you're not going to get that diagnosis, but you'll get some information about what the child needs at school. So the person who completes the testing sometimes works with the child. It's free. You can ask for an evaluation through your school system, and they have to provide some kind of evaluation. You can seek more information if you don't like the evaluation. But on the other hand, if you're unhappy with the evaluation at school, the child has to go through that same process over again. So let's talk for a moment then about, okay, you've got the diagnosis. What is ADHD? Well, one of the things we know about ADHD now is that it's not just one thing. We know it's not a behavior disorder. We know it's not something that people can just, have those symptoms and just sort of will themselves out of. It has a lot of different factors, environmental factors. We know that there's a very strong genetic component to ADHD, and other things like a central nervous system insult, a problem during birth, a early brain injury in early childhood. Any of those things can increase our risk for having ADHD. And in terms of etiology and incidence, it's more common in girls than boys, although we think that might be because we don't do a very good job of diagnosing girls. They tend to have more of the inattentive symptoms. Their problems only cause problems for themselves, not for the people around them. When boys tend to have ADHD, they tend to be more impulsive and hyperactive, so they're getting in lots of trouble. When girls have ADHD, they tend to just not pay attention, so they can sometimes slip through the cracks. You can see some of the other prevalence rates. It might seem like everybody in the world has ADHD, but depending on the prevalence rates, it can be anywhere, if you look at the statistics, from 5% of the population to, as you can see, from 2003 to 2011, it had increased a fair amount. Right now, somewhere between 5 to 11 or 12% of the population is thought to have ADHD. The prognosis includes these facts, that hyperactivity and impulsivity tend to get better as we get older. And about half of the kids with ADHD will continue to have symptoms in adulthood. But that also means that half of kids with ADHD won't really have symptoms in adulthood, or they may have one or two. They may just say, I'm really disorganized, or I still have trouble kind of like paying attention when somebody tells me their name at a party, but they won't have the full diagnostic criteria. A couple of other things to keep in mind, that when you have ADHD, especially untreated, you are at increased risk of suicide in adulthood and increased risk of obesity, among other things. That does not mean that having ADHD leads to that, but it increases your chances of one of those issues, among other things too. And I emphasize the untreated ADHD. So just to take a look at this again, the course of the disorder, as time goes on, those inattentive symptoms stay, and the hyperactivity and impulsivity tends to decrease with age. But what does inattentive symptoms mean? Well, it means you're not as productive at work. You're late for work. You're late to meet friends for dinner. You make a lot of more mistakes. You're disorganized in a way that really makes people upset with you. you might have a disrupted workflow, meaning that you start one thing, you go on to another thing, and nothing gets done. So those inattentive symptoms that seem like, yeah, I just don't pay attention very well, actually can lead to big problems on the job. And it can lead to other sorts of complications too. So untreated ADHD, there's an increased risk of injuries of all kinds, increased risk of driving offenses, more substance abuse reported, more cigarette use and abuse reported as well. And then we know that people with ADHD have increased risk of other sorts of psychiatric issues. This is really the case with all psychiatric issues that we study, is these things don't happen in a vacuum. And oftentimes these sorts of issues like ADHD are comorbid or co-occurring with anxiety, with conduct problems, with depression, bipolar disorder. So it's important to know that, because oftentimes the person who's doing the treatment needs to keep in mind that sometimes it's not just the ADHD that needs to be treated. Other things that are associated are things like tics, having trouble with sleeping. There's even a study that showed loud snoring at ages 2 to 3 increased the risk of ADHD. We don't know why that is. And ADHD and enuresis, meaning bedwetting, or encopresis, meaning trouble with bowel movements. When you're younger, either being overly constipated or not being able to control that, those might be due to the fact that people with ADHD lose track, especially think about a 6-year-old who's engrossed in their play, overly focused, which is another thing that happens with people with ADHD. They get overly focused and they forget that they're supposed to be doing something else. The same thing can happen in terms of toileting. And sleep disturbances are something that are so common in people with ADHD that some people have discussed the fact that maybe that should be part of the criteria itself. There are lots of problems with sleep in people with ADHD, not wanting to go to bed as a child, difficult waking up in the morning, perhaps because they didn't sleep well the night before, they just spend less time sleeping. So for many physicians, where they will start their treatment is with trying to fix the sleep problems. I think that some of the issues with sleep are the fact that people with ADHD have trouble with what we call shifting set, moving from one activity into the next. They get overly focused in what they're supposed to be doing, and so they forget that they're supposed to be moving on. Video games is a good way of a good example of that. Child gets so engrossed in their video games that they forget that they're supposed to be doing their homework. Well, bedtime is something that we actually have to focus on. We got to focus on the fact that we need that bedtime ritual. And so people with ADHD tend to have trouble with that. So again, an evaluation wants to look at all of these things. You want to get information from multiple sources, teacher and parents. You want to look at whether or not there are other issues underlying the child's problems. Are there other sorts of things going on? Speech issues, learning. Is their hearing okay? I want to make sure all those things, all those questions are answered. I want to look at home and school. So even if you get an evaluation from your child's pediatrician, the pediatrician should be looking at all of those things too. I mentioned too that it's really been very recently that ADHD onset can occur in adulthood. And this is an article, an editorial done by two of my colleagues at Mass General. One, Joe Biederman, who's sort of like what we sort of think of as the grandfather of ADHD research, who passed away last year. But it looks at whether or not ADHD could onset in adulthood. And there is a case to be made for that perhaps for some of us who overcompensated, this might be particularly true for women who might have been, have difficulty paying attention, but sort of made it through school, became uber organized. I do find this to be the case for even ADHD adolescent girls. They become overly fixated on their note cards, their Post-it notes, their different color coordinated pens and pencils. that when those women reach adulthood or middle age, when they have a lot of things on their plate to have to organize, they may present with significant problems at that age. So it's something to think about. It's something that's being researched as we speak. So what do we do then for ADHD? I've made some reference to this, but ADHD treatment is most effective when it's multimodal, meaning medication, education, and behavioral treatment. And as a parent, you don't have to do all of these things, but I think it's important that you have an understanding of all of them. Medication has actually been shown to be exceptionally effective at treating the symptoms of ADHD. You might be a parent. I was one of these too. I should disclose I have a son who's in his late 20s now with ADHD. I myself, even though I was in this field, was very reluctant to put him on medication. It's just what we do as parents. We want to protect our kids. But it is the stimulant medications that are used to treat ADHD are some of the most studied medications in all of medicine. It's much safer than antibiotics, for example. And I didn't think twice about putting my daughter on prophylactic antibiotics to treat her ear infections, for example. So we have sort of this stigma about medication used for ADHD. The two kinds of categories of ADHD medication are stimulants, and within that, you can see there's methylphenidate and amphetamines and non-stimulant medications. I've only mentioned a few of them. I know that there are lots of different medications. There are always new brands coming out, and sometimes I can't even keep up with them. But one thing to keep in mind is stimulant medications stimulate the part of the brain that's understimulated. So for people with ADHD, the frontal lobes of their brains, the part of our brain that helps us control our behavior, that helps us plan ahead, that takes all the information from the rest of our brain, the language system, the memory system, the motor system, and it takes all of that information and tells us, respond now, remember this, pay attention to that. That part of the brain in people with ADHD is understimulated. So a stimulant medication helps that part of the brain become more active and more stimulated. So a frequent question that I get is, how can a child with ADHD who's overstimulated, how can stimulants help them? That's why. You can see the list here of side effects. Kids can have a loss of appetite. They can have sleep problems. Problems with growth has been thought to be a possible issue. Research that has come out has shown that there really isn't any impact on growth. You can have what's called rebound effects, meaning that a child takes the medication in the morning, especially if it's a long-acting medication. By 4 p.m, the parent goes to pick the child up after school, and the child is out of control now because there's a rebound effect. That's something I always recommend parents talking to the child's doctor about. Tics are also something that are common, or not common, that are a side effect of medication. One of the things to consider, though, that 10% of kids with ADHD will have tics of some sort, eye blinking, throat clearing, whether they're on or off medication. It just is something that is co-occurring in a lot of kids, 10% of kids with ADHD. And then you might also see mood changes in kids who are on medication. If you do, that is a red flag. There is no reason for a child's behavior to be affected negatively by medication. You should, as a parent, see your child become more of themselves on medication, not less. And if you're finding that to be the case, you definitely want to talk to your doctor. That is not the case. So I hear a lot of times, well, I'm a really creative individual. I'm afraid that ADHD is going to stifle my creativity. Nope, it should not work that way. What should happen is, as a creative individual, you should actually get those projects, those paintings, that writing, that book done when you're on ADHD medication, not the opposite. So the kinds of treatment benefits that we see, better learning and education, this comes from a wealth of studies, this list. Fewer accidents, less criminal behavior. It could be anything from just misbehaving, better social interactions, and better employment opportunities. So again, when you have a child with ADHD, life should look like Monday, Tuesday, Wednesday, and Friday. And when they don't take their medication, you say, oh my gosh, really, it's a huge change. And it should be a positive change. So I mentioned before too that the best treatment options are multimodal, meaning medication and therapy and behavioral changes. There are some kids for whom medication just doesn't work. In a small group of kids, certain medications don't work, certain groups of medications don't work. Sometimes it's a bit of trial and error, and there are other things that we can do. I've mentioned here that below the age of 6, it's really recommended to start with behavioral approaches first. Sometimes even kids under the age of 6 benefit from medication, and typically it's because they can't control themselves in many situations. Life is becoming difficult. They've gotten kicked out of preschools or kindergarten, and parents are willing to try anything. But in general, behavioral approaches are the best place to start. Ages 6 through school age, there's a lot of evidence that shows medication works very well. And I believe too, though, that school-based supports are needed at every age, whether a child's on medication or not. And what are those kinds of strategies? Well, I've put a few here. You can see that more opportunities for movement, the kind of child who we don't want to take away their recess. That can happen as punishment. That's not a good punishment for kids with ADHD. Chunking long-term projects. A teacher really positioning a child in a classroom where it's easier for them to pay attention. The use of timers, teaching executive function skills like organization, time management, those sorts of things. And I wanted to mention time management too, because this is a more recent area of research. And I've done a few studies on this. And people with ADHD have been found to have problems with time perception, which is different from time management. So time perception is the difficulty knowing how much time has passed. So for people with ADHD, sometimes they don't know the difference between 20 minutes and 45 minutes. And I spent years telling parents that they should help their child learn time management skills, when our recent research has really shown that kids with ADHD have trouble with time perception. So they don't understand the concept of time. And I'm putting this here, I put those little pictures there because we all kind of understand now what time perception is, because having gone through COVID, we all lost a lot of our sense of time. So we didn't know, like, what month is it again? What time is it again? What day of the week is it again? That's how people with ADHD feel a lot of the time. So one of the things we want to do for kids with ADHD is help them develop a sense of time. So develop tools to understand that, because without an adequate sense of time, you can't use those tools. It's like trying to manage, it's like putting all the recommendations on the board, but a child can't see the board because in their back of the classroom and they don't have the sight to be able to see them if they have an impairment, a sight impairment. So one of the things that I recommend are use of a personal calendar so they can visibly look at what's happening. I put that up there, that daily schedule. Using stopwatches, not to just time, like how long does it take me to get my homework done, but how long does it take me to do fun stuff? That helps them develop an internal sense of time. Okay, yesterday we didn't have any traffic, so it took 15 minutes to get to school. Today there was a lot of traffic. It took 20 minutes to get to school. How did that feel? I also am a big believer in teaching a child how to read an analog clock. I've heard from lots of kids, oh, I don't need a clock. I know what time it is. Not true. And looking at an analog clock really helps you see time passing. Other treatments include help for sleep, better sleep hygiene. Neurofeedback, it's sort of mixed in terms of the data on that. It's not something that I really recommend. It usually takes a lot of time, and I think are better things to use. school supports, which I mentioned before, executive function coaching, sort of like homework support that can help kids learn to apply organizational skills, can also be very helpful. I mentioned adult ADHD, just going to swing back and say adult ADHD, again, don't have great data on this, but probably 1 to 6% of adults, affects academic performance, interpersonal relationships, employment. More driving accidents are associated with untreated ADHD in adults. Not a lot of studies, but something that is increasing in terms of our quest for knowledge on this. There's a lot of evidence that shows that Ritalin and those sorts of methylphenidate derivatives work very, very well. And the side effects are not typically as significant as they are in kids. I see that there probably are some questions in the chat. Let me just go over a few different things in just a couple of minutes, and then I'll open it up for questions. So the two things I get asked most often is, how do you know it's ADHD, and what about medication? I hope I've answered some of those, but how do you know it's ADHD? Get a great evaluation by an evaluator you trust. If you have questions as regarding the diagnosis itself, ask them. Make the evaluator really tell you why they came and how they came to that conclusion. And medication, I've already mentioned. I mentioned this is a common question that I get. My child is the opposite of hyperactive. It takes a tornado to get her moving, yet the psychiatrist diagnosed her with attention deficit hyperactivity disorder. I hope that I answered that question. The label can be confusing, but it's ADHD inattentive presentation. And then I think I'm going to skip over this one and just say one other thing. This is a question that I get very frequently. The neuropsychologist who evaluated my child said that they had ADHD and dyslexia. How do they know it's both? And I want to just point out that there is a high co-occurrence of ADHD and dyslexia. I've seen a lot of kids who were diagnosed with ADHD, were on medication, were helped by medication, but their dyslexia, their reading disability, was never diagnosed. And so they still struggled in school. If that is the case for you, get more information. Definitely, a child should be doing well in school. ADHD, even though kids with ADHD can sometimes be a little slower at learning reading skills, they catch up by 2nd or 3rd grade. And that's because it takes a lot of attention to learn to read. But in general, if your child's in 3rd and 4th grade and being treated for ADHD, still struggling with basic reading skills, you should have that evaluated as well. So I think that I'll leave it there and just review that again. ADHD, complex disorder, strong genetic component, affects millions of people, persists throughout adolescence. But I want you to also just keep in mind a very highly treated disorder. So I left about 10 minutes for questions, although I can go back and talk about literally anything.
Thank you so much, Dr. Braaten. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. We have an attendee who thanks you for this excellent presentation. They echo their value of medication in addition to other interventions that you're sharing. Can you speak to the challenges that some may have with the availability to some of the ADHD medications, especially XR? This person in particular has experienced this and knows several in their community do as well. Is it perhaps isolated? This particular person is located in the South Shore.
Oh, so do they want a recommendation for a person on the South Shore, or I didn't?
More about challenges in the availability of medications, especially XR.
Yeah. So I think I'm not sure if this is what they're talking about, and just feel free to put this back in the chat. It is really tough because people with ADHD have to, because these medications are controlled substances, and I didn't put that in, but I sometimes talk about that. It is something that you can only get the prescription for a certain amount of time. And this is the hugest, most tragic irony for people who have trouble remembering things and staying organized, that they have to remember and stay organized. I see this here. I'm asking about availability of meds. I don't know what to tell you about that, to be honest. I really don't. That there is a shortage of medications right now. And I think that it's just something, learn to make friends with your pharmacist. And it's they put in the chat, it's a tragic reality. It really is. So we've got almost like a double thing. What I was starting to talk about is it's hard for people with ADHD to remember to call in their prescription every 30 days or so. And then on top of that, they get the prescription and can't get the medication. I think one of the things you can do if you're an adult or even a parent of a child with ADHD is to be honest with the people that are around them. So if you can't get that medication and you're a parent of a child with ADHD, you just be honest with your child's teacher and say, I am having trouble. Listen, we've done everything we can. We have the prescription. We can't get it. I need your assistance in helping me do this. Yeah. Be honest and open. And oftentimes people can empathize with this, but it is a huge problem. And obviously I'm not the person to solve this problem, but it's really tough.
Thank you. We have a question regarding being on medication. Is medication something that a person will stay on until adulthood and stop, or is it something that the person typically continues indefinitely? Or
Excellent
when older,
question.
is it something that is taken as needed?
Excellent question. There are a lot of psychiatrists who feel like in childhood, if ADHD medication works, they should take it every day of the week. Other parents say that I don't have any trouble with it on the weekends, so I would just prefer to just keep them on it during the school day because it suppresses their appetite. But most psychiatrists, at least the ones at MGH, and I should say that my colleagues at MGH have been the world's foremost researchers on ADHD. Most of them feel right now it's a chronic condition in childhood. If it works, it should be taken daily. But you have that option. I sort of, in terms of my clinical work, have seen it work in different ways, that at different times of a child's life, they need it every day. They're in middle school. It's the stakes are high to really mess up in middle and high school. They take it all the time. And then there are also cases where life is going well, they go off of it, they learn that they're having problems. So it's one of those things. I think it's a tool in the toolbox. I think it's a very important one. It's one that's been very well researched. And I think that I've worked with adults who are like, I am never going off my ADHD medication. It changes my life, period. And others who say, a lot of times I don't need it, but when I get a promotion at work or things get really stressful, I can't live without it. So it really is one of those things that you have to determine for yourself what works better. The nice thing about ADHD medications is that they're short acting. So for most of them, not all of them, but for the stimulants, it's short acting. So you can take it one day, it'll work, and you don't have to take it every day for it to build up in your bloodstream.
Thank you. Do you have any recommendations on how we can support a teen who doesn't feel motivated at all to manage their ADHD symptoms? For instance, they might think, I spend 7 hours in school a day, that's not enough.
Yeah, motivation in teens in general these days is a big question. It's what you mentioned. I wrote, and I'm not selling my book, but I wrote a whole book on it last year on how to motivate your child because this is so common. One of the things you want to do with an adolescent is just open the discussion. I think one of the key things to do is to talk to your adolescents. What do you want to get out of this year in school? Where are you going? What do you want to do? And to talk about what are the skills they need to get there, what are the sorts of supports they need in order to get there. So if you've got an adolescent who's like, well, yeah, I want to go to college. Well, great. Here are the things you need. Can medication help you with that or not? can executive function tutoring help you with that or not? The other thing that I find with teens with ADHD, teens in general, who are unmotivated, is sometimes they're unmotivated because they don't like the course you've set for them. So they're on the course for college, but they don't want to do college. And lots of kids with ADHD are kind of out of the box thinkers. And I personally think we need to start thinking outside of the college at all costs box and start having conversations with them. You seem really unmotivated. Listen, I always thought you were going to college. You're telling me by your behaviors that school isn't your thing. What is your thing? And to have lots and lots of those kinds of discussions, that can actually help increase their motivation. And also, maybe they want a job right after college, an apprenticeship. Great. You're going to need to get there on time. Can medication help with that? Can the kinds of supports that I'm mentioning help with that?
Thank you. We have a question regarding ADD. How can parents support young adults diagnosed with ADD in college?
Such a great question. So one of the things you want to make sure you're doing is maximizing the support already at the college. Every college, from Harvard to every community college and everything in between, has services and supports for kids with ADHD. You're going to need some kind of an evaluation. You're going to need to meet with that. And I really encourage parents and students to go and meet with the people at the support services center at your university so that they are maximizing the supports that are available. And if you don't have an evaluation, get one, and they can help with that. And so I think that's really important. That's the number one thing. Keep in touch with them, like keep up with them. I'm not a big, I don't really think we should be hovering over our college age students, but check in with them once or twice a week. How are things going? What I find is that when things go off the cliff in college, it's usually because parents haven't checked in. It's been like 2 or 3 weeks and parents are like, I haven't heard from them at all. Things must be going great. And you find it's been the opposite. So keep in touch and let them know. But also the other thing too that can be complicated is that if your child's on medication, it can be very complicated if they're out of state to find a provider who can prescribe the medication. So make sure if that's something that they depend on, that you've talked with their pediatrician, psychiatrist, and figured out a way for them to be able to get their medication consistently.
Thank you.
I saw something about estrogen and women as they get older and ADHD.
Yes, this person has heard about a connection between estrogen and cognitive function in relation to women with ADHD, especially midlife. Can you speak to that in terms of existing research and treatment?
So I'm not super familiar with this research, and it really is just emerging, and the question is correct. There is a link between this. I think we know so little about menopause, premenopause in women. We know almost nothing, to be honest. And so this is the sort of thing that I would just encourage you to, I don't even feel like the data is enough for me to say anything definitively. I would just really encourage you to talk with your doctor, to stay educated as best you can. There is a great Center for Women's Health here in the psychiatry department. They're a great resource to look at this. But I think that it's really tragic how little most physicians get no training at all in menopause at all. And so these sorts of links, which I think are there that we just don't understand as well, are things that we'll learn more about as time goes on. But I think ADHD in women, perimenopausal, menopausal women is something that's been incredibly understudied. And it also happens at a time in life when women have children, they have adults that they're taking care of, they're sort of at the peak of their career or trying to, re-enter the workforce. It is a really tough time, and I would just encourage you to stay informed. I wish I had a better answer.
Thank you. So I know we are at time. Do you by any chance have a few more minutes just to go over quickly? We have like a few questions in the chat. Okay.
Definitely.
Do you see the gap close with executive function at a certain age? Often people have suggested ADHD children, often described as doers, for example, being a bed maker or a room cleaner.
Yeah. So you mean I'm curious about this. So ADHD, like they get better at executive functioning as they get older? Or I've never heard this. I
I'm
like
not
this though.
sure. We can always
Okay.
skip that. Yes,
Yes.
yes.
So no, okay. So executive functioning definitely is related to brain functioning. And it was always the case that, we thought like, well, maybe in early, sort of like our early 20s, our brains have developed in a way that allows them to have sort of adult executive functions. I will tell you that it's my clinical experience that lots of people with ADHD, they don't have those functions until late 20s, early 30s. Like I've seen lots of young kids grow into young adulthood, not make it in their college, or just sort of like mumble through college, but reach their beginning of independence at 29. And so give it some time, be supportive, love your kids, and just know that most of them grow up. But I used to get very impatient because I tell parents, oh, once they're like 8, 19, 20, 21, the brain period, pretty much. But no, it really doesn't. And again, this is another thing that's understudied, is our brains as we move through life. It's not, when I went to school, I was sort of taught that, most of the brain is developed by age 6, and, the first 3 years of life are most important. They're important, sure, but our brains are always changing.
Thank you. If a child has multiple neurodevelopmental issues in addition to ADHD, how often should they have neuropsych evaluation to ensure they're getting services they need? Does it depend on the age or other criteria?
Very good question. I would say, to be honest, there are lots of people who say you don't need neuropsych testing to diagnose ADHD, and they're right. But neuropsychological testing can be so helpful in figuring out the what. What do we do? So my rule of thumb is every 3 years is great. That's the term that you have to have a reevaluation done under the law, IDEA. I feel like that's a pretty good gauge too in terms of private evaluations. But if your child is struggling, don't hesitate to get an evaluation. And if they're doing well, it may be that they don't need anything for 5 years. I've seen lots of kids who I diagnosed with ADHD at age 7. They did great all the way through elementary school. And I don't see them until 8th grade when things get complicated or the parents are worried about high school. And then I've seen other kids with ADHD, especially those who have a learning disability, either disorder of written expression or reading, who I need to see sort of every year or two in order to make sure they're getting the proper services. A lot will depend on how well the school is providing services and implementing those.
Thank you. All right, so one final question. Are there varying degrees to symptoms of ADHD where equal to or more than 6 symptoms of ADHD? For instance, someone has some level of inattentiveness, is pervasive and frequent, but not crippling. In other words, can someone have ADHD to a lesser degree than someone else?
Yes, definitely. I mean, there are some people who cannot attend at all, and then some who have trouble attending in certain situations. I also think, and this gets back to one of the first things I said, we can all have a bit of these sorts of symptoms and be impairing in the right sort of situation, but we can figure out how to get out of them. And so it might be that someone has sort of borderline symptoms of ADHD. They have on the, sort of like right at the diagnostic criteria. In the right situation, not a problem at all. In the wrong situation, huge problem. So people who had sort of like mild, always struggled, and there are a number of people like this during COVID, for example, mild issues with ADHD, their whole history, never needed treatment, always sort of pulled it out. And then all of a sudden, they're at home on Zoom, managing a million things. And one of the ways they might have coped was to be uber organized, uber busy. That's another thing that women often do. They just plug in their calendars. So they know exactly where they have to be. Well, that just took everything away from lots of people who might have been in that gray area and caused them to really have trouble paying attention. They were late for Zoom meetings. They might, do you know what I mean? Late for the sorts of things you shouldn't be late for. So that definitely is in any of these disorders that we talk about. There's always that gray area, and it can be, managed a lot by the environment and also triggered.
Thank you so much, Dr. Braaten. This has all been extremely helpful. Thank you for spending the extra few minutes with us.
Happy to do so. Thank you so much.
And for everyone who joined us today, thank you so much. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, it will be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.